The longer follow-up that we have, the more we're feeling confident that if patients obtain a response that they maybe can get a durable response for this. So if we're thinking about this term not fit for auto, the question is it that they're not fit because they're not fit for high-dose intensive therapy, or are they not fit because their disease response isn't good enough to that high-dose therapy, so they haven't achieved a PR or a CR, so we don't want to take them to auto. And if that is the case, we would give them a second-line therapy and then either use CAR T. We know that we are getting flattening of the curve for patients who obtain a CR, for patients who have had CAR T. So we are talking durable responses. I do think that some of these patients are cured. We can think about other treatment options for the auto-ineligible. So maybe if we think about the less fit patients who have got durable responses from Rituximab, Bendamustine, Polatuzumab, from Tafasitamab, from bispecifics in the only the follow-up that we've got. So I do think it's possible to obtain a cure for these patients. I think that obviously when we understand patient selection better, it will allow us to have that discussion with patients. At present, when I'm in clinic, I'm very cautious about using the word cure in the relapsed refractory setting for these either non-disease responsive to high dose, ineligible for auto patients, or these less fit patients, because we have to be realistic that many patients will still sadly go on and progress. And this is the important part that we mustn't ever forget. In a relapsed refractory setting for high-grade lymphoma, sadly, many patients do die from their disease, and that's still the majority. So we must involve our parallel planning technique, we must involve our palliative care colleagues, and although we can hope for the best with these newer therapies, with trial options, we do have to plan for the worst and make sure that we have had realistic conversations with our patients so that they can speak with their family and make sure that their wishes are honoured if they've had to plan for the worst. So that's important. We mustn't just get so focused on these newer, excited, targeted therapies. We've got to make sure that we have realistic conversations, even if we are hoping still to get a long-term response.